all for giving me the opportunity to kind of talk to you today about my passion and what I've been doing for the last few years. Goals for today, for me, are basically to have people really understand what the burden of pediatric cancer care is worldwide, what some of the challenges that people face when trying to treat children with cancer in a global setting, and then to really evaluate how we can go about creating capacity development in many low-resource settings. So childhood cancer, there are about 400,000 cases a year that are diagnosed. Now, I phrase that, there are 400,000 cases per year that we expect to be diagnosed. The reality is, you can see here, that in Western Africa, almost 60% of cases that are expected are never actually diagnosed. I mean, the majority never make it to a medical center. So these are estimates based on what we know in countries like the US and places with cancer registry applied to the population that we know. So for example, we know that in low and middle income countries, there's a much higher proportion of children living in those countries, right? So population less than 15 years of age, about 88% of the childhood population lives in low and middle income countries. So understandably, the majority of cases of childhood cancer should occur in those countries as well. But 83% of what we estimate occur in low and middle income countries. So the bulk of children with cancer are being diagnosed or not being diagnosed in low resource settings around the world. Why that's important is because 80% of children who are diagnosed with cancer here in the United States, overall survival is actually higher than this in the US, 85 to 90%, depending on your type of cancer. But in children in low resource settings, that survival rate is only 20%. So in a place where the majority of people who will be diagnosed live, their chance of cure is abysmally low compared to what it could be. To help address this, the World Health Organization started in 2018 in September. They announced the Global Childhood Cancer Initiative. Their goal is to basically increase the rate of childhood cure, so the increased survival for children with cancer to 60% by the year 2030. They are trying to work with governments to do this by supporting local government, local hospital capacity to both diagnose and treat, but then also kind of work with ministries of health, work with policymakers, try to get pediatric cancer as part of a national protocol, part of a national dialogue about cancer treatment. So look at the numbers. There's 400,000 new cases per year. So these are the number of children who will be diagnosed in low and middle income countries. With a 20% survival rate, that means there'll be about 260,000 children who will die this year because of cancer. The goal of increasing to 60%, so not 80% in high resource countries, but at least 60% in all these countries, will save over 200,000 children's lives every single year. So in about 5 years, the goal is that we will save 1 million children's lives by trying to improve our care, treatment, diagnosis, and registry of children with cancer. So why is this going to be difficult, or what are the challenges that people are going to face to do this? Well, if you think of cancer care, it is not just one thing, right? It's not just one discipline. It involves many different types of treatments. So you have to have the oncologist, you have to have a surgeon, you have to have radiation. That's the core. The reality is, in order to properly treat cancer, you need all of these different pathways. You need pathology, you need solid nursing, you need social support, you need palliative care, radiology, rehab services. All of these different groups have to be in play and functioning at a high enough level that you're actually able to make an impact and actually able to help treat these children. If you look at here in the US, this is typically done in an oncology center, right? Like we have here at Duke. So there are 895 designated oncology centers here in the US. That's one for every 350,000 people. There are 120 cancer treatment centers in the entire continent of Africa. 22 of those are in South Africa alone. So that becomes 1 for every 10 million people in the population. Severe shortage. The majority of those who actually go to a cancer treatment center aren't actually receiving adequate care because of missing resources. It's hard to diagnose cancer in many places. So symptoms that could be early symptoms of cancer are pretty general, right? You could have someone who's fatigued, someone who has pallor, headaches, knee, joint pain, aching. All of those can be pretty much anything. And if you go to any of the local community clinics, for example, where I work in Tanzania, your opportunities are you can check a hemoglobin, okay? We can check for typhoid, malaria, and a UTI. So I will tell you that almost 90% of our patients who come to us, when you ask where do they go, they initially went to the local health clinic, the dispensary, sometimes one of the district hospitals. They were told that they had at least 1 or 2 of those things at the same time, and that's what was causing their symptoms. So as a result, you end up with significant delays in diagnosis before people actually recognize that this could be cancer and they're referred. To add to that, if you're trying to do imaging, you need to have imaging tests to be able to differentiate where they are. Most centers will have ultrasound, which is good for certain things, but it doesn't give you that kind of more detailed information that you need to actually help make the diagnosis. If you do find something and you're able to get a sample of it, then we have the problem of pathology and access of actual diagnostic. So there's a severe shortage of trained pathologists, in Africa most notably. Some countries don't have a single pathologist at all. And we have 15 pathologists in Tanzania for 50 million people. So 1 for every 2 to 3 million people. In the US, it's 1 for every 19,000 people, for comparison. Where we work, there are now 2 pathologists, I stand corrected, for 15 million people. Surgical access is a big issue in this region. I know a lot of people in DGHI have looked at access to surgery in this. So for example, access to a surgeon, and not a pediatric surgeon, this is just access to a surgeon who could potentially do biopsy and do any of the resections. US, 65 surgeons for every 100,000 people. In sub-Saharan Africa where it is less than 2 for every 100,000 people. So even if you find something, you recognize it might be cancer or something that needs to be taken, reviewed, evaluated, removed, you may not be able to find someone who's done it. Radiation, I apologize, the picture's gone. Not sure where it went. So in radiation, there are 227 machines for all of Africa. That's 1 machine for almost every 5 million people. And the IAEA, which is kind of the International Atomic Energy Association, they said that there should be about 1 for every 300 patients, or about 1 for every 20,000 people. So we are woefully under-equipped to manage the radiation need. And finally, palliative care. 22 countries in the African continent have no access to palliative care at all, in any formalized or unformalized setting. That means no access to morphine, no access to supportive infrastructure, no access to nursing, follow-up, pain management, nausea management, any of that, okay? Plus then you have the additional barriers of trying to do this, where hygiene standards may not be quite as good when you have people who are immunosuppressed. There's high risk of infections. Nutrition is limited. This is me one of the times that I had cholera, so it can be an issue for someone who is already weakened by giving chemotherapy. Then they get malaria, or then they get some other infection, and it could take a very significant toll. So I want to talk about the very first patient that I ever had in Tanzania, to kind of put into perspective what it looks like for a patient who would be presenting and diagnosed and being treated there. So this is Regina. So she was initially seen, and she's 11, as you see here, she was initially seen in a local health clinic, presenting with fatigue, and because all they had was a point-of-care hemoglobin stick, she was told that she was anemic and required a blood transfusion. They didn't have a CBC, so the ability to see the white blood cells or the platelets or anything at that time. Eventually, they referred her because she required 2 or 3 blood transfusions. She wasn't getting better and she had fevers. They referred her to a regional hospital. Regional hospital, they did have a CBC and found that her white blood cell count was 35,000. Normal is about 8 to 12,000. So significantly higher. And they sent a smear, sent it to a person to look at. About 5 or 6 days later, they got a response. They think they see leukemia cells. So then they referred to our center. So there are only 2 places in the country that treat cancer at that time, our site and the one in Dar es Salaam, which is from where we about a 17-hour drive. So they chose to come here, which was only about a 5-hour drive for the family. The family had no way to pay for her treatment. So when she arrived, at the time, there was a study going on for Burkitt lymphoma, where they were providing 3 chemotherapies for free for patients. So the center had those 3 chemotherapies. They decided that she had leukemia and started her treatment with those 3 medications, 1 or 2 of which are actually what we do use for leukemia. Third one is not. While this reduced the cancer burden, she didn't go into remission. And then they weren't able to pay for, the first time she came in, she had a fever with neutropenia, and they weren't able to pay for the antibiotics that she needed. So we had to see if we could ask other families that were on the ward if we could borrow theirs. Because for anyone who works in oncology, it's critically important if you're neutropenic and have a fever to reduce the risk of sepsis and death is to initiate antibiotics right away. So we had to request from other families if we could borrow, and we would try to repay later. Eventually, we got her out of her sepsis, and the dad was asked to pay for the hospital bill, could not. So he asked for a begging license to go into the community to request funds from his community to help pay for her hospital bill. She was in remission. We came in, switched her chemo, gave her a proper chemo. She finished induction. She was in remission. She came back and required a blood transfusion. Her hemoglobin was 3.5, which normal is about a 10, significantly low, and this was a Friday. The cost of a blood transfusion is $3. Family did not have it. So they wrote to their family members to send them the money over the weekend, and on Monday she died because she never received a blood transfusion. So this is not, unfortunately, a unique story that we have in many of these rural resource settings. Kind of demonstrates the additional burden that we're doing. It's not just about what technology we have. It's not about who is there. It's about thinking of all the different social aspects, cultural aspects, economic aspects that are going into these families' decisions as well. So this is where we work. This is Tanzania Peds Oncology Interview. So as part of the Global Cancer Program, which started in 2014, there are 3 sites, Collaborators in Brazil, Kata Memorial in Mumbai, and then our site in Mwanza, Tanzania, Bugando, here. So there are 3 total sites, KCMC, so Kilimanjaro in Moshi, which is also Duke affiliated, which is not for oncology, and then Ocean Road or Mbili, which is the main capital. So what I did when I first started there in 2014 is you have to think of, well, one, my job was to go and build research capacity. That's what it was. When I arrived, however, I realized that there was absolutely no clinical capacity. So I was one of 2 pediatric oncologists in the entire country, the other one being in Mbili in Ocean Road. And so for our site, there wasn't anyone else to treat these children. And so I got pushed into doing both clinical development, clinical care, as well as trying to build the research capacity so that we could figure out what works, what the right thing to invest is, and how can we build our infrastructure there. Anytime you go into a country, context, city that is not yours, You cannot go in, I cannot stress this enough, with what you think will work there, or what you think somebody needs. You have to, from the beginning, understand what exists, understand what is already in place, and then understand what the needs, as they are interpreted by whomever it is that you are trying to talk to, collaborate, work with, what it is that they think is important, and then find a way to build on that together. So my first step was resource, trying to figure out what existed. So the most common types of cancers that we see, Burkitt lymphoma is number one. This is because Burkitt lymphoma is something that can be associated with malaria and EBV co-infection. So in endemic malaria areas, we see a much higher proportion of Burkitt lymphoma than we would see in other parts of the world. So we had about a little over a quarter of all of our patients had Burkitt lymphoma. The other thing that we saw was Wilms tumor. Okay, so kidney tumors. Eye tumors was also common. In the US, brain tumors, leukemia, number 1 and number 2. Okay, most common things. Leukemia eventually made the number 3 spot, but brain tumors aren't on there at all. Any guesses why?
Undiagnosed.
Yeah. And the things that we're seeing, so we don't have a CT scanner at that time. So there was no way for anyone to diagnose that there was a brain tumor. Okay? Leukemia, if all I do was the hemoglobin check and there's no hematologist there, I was the only hematologist, and I was only there 6 months out of the year, there's no hematologist to diagnose that this is leukemia. And so you're just not seeing them because they weren't diagnosed. It's not that they don't exist, they do. The most common things we see are kidney tumors, eye tumors, because they're slower growing and it's visible. So people come, okay? So when you look at this sort of epi-distribution of what people have in low resource settings, look at it with a questioning eye as to why. Why is it that we're seeing those as the most common? You will see over time that as capacity develops, we are seeing more leukemias. We are seeing more brain tumors now. I had 3 last week alone, now that we have a neurosurgeon and a CT. Clinical capacity. So when I first arrived, we had 1 medical, so adult oncologist, 1 radiation oncologist who was trained in India, 2 kind of hospitalists. So there, people do medical school, and then when you graduate medical school, you do a 1 year of intern, and then you kind of work in the area of your interest. So we had 2 people that were physicians, but were not subspecialized in anything like medicine or pediatrics, whatever. So they were learning how to take care of the patients. There was 1 pharmacist, and we had 8 nurses. Laboratory. So we had both biochemistry, we have biochemistry, microbiology, they've been accredited. There was a lot of work and influence that was put in for HIV research and work in the past. So things that were necessary for HIV care were more developed at that time. So we had microbiology, we had some PCR, we had CD4, CD8 that could be done just for those. And then the issue that we ran into is that while we did have a CBC machine, chemistry, we often ran out of the reagents. So even though I could run what we call a chemistry, the creatinine might be gone that day. So you just don't have that result. The turnaround time for labs initially was about 2 days. So you would submit the labs and then 2 days later you would get your results back. There is a blood bank that can supply blood into the hospital, but there's a chronic shortage of blood supply. At one point in the hospital, it was mandated that if you were going to receive a unit of blood, 3 family members had to come and donate and sign off that they had donated blood to be able to receive a unit. Unfortunately, that led to many deaths of some of our children who were not able to get blood in time. So that rule was changed, but it's still encouraged to have as many people donate. And diagnostic capacity. So we had an X-ray and ultrasound. Last year we got our CT scan. But because they are so busy, they don't read the X-rays. So this is me reading one of the chest X-rays with pictures on my wall behind it. So you end up being the radiologist, so you have to make a lot of these decisions looking at X-rays. Pathology, there's 2 for 15 million people. All we have is morphology, meaning that you can look at it and H&E. People who are familiar with it, you can see what it is, but we don't have any of the fancier immunohistochemistry or other techniques that are needed to definitively diagnose something. And we had general surgery and urology and ENT. Since we have gotten a neurosurgeon who has come, I will update a little bit in this, in that what we had to do from a workaround standpoint, and this is what I still do to this day, is my pathology is sent to Ireland. So all pathology samples for children get collected at one site in Dar, and then get sent to Crumlin Hospital in Ireland, where they process them all for free, including all of the immunohistochemistry and everything else. This hospital in Ireland does more pathology for children in Tanzania than all the children in Ireland that they see. It's a free collaborative service that we have worked out. We're trying to increase capacity for immunohistochemistry. We just got our first manual for immunohistochemistry, so we are working on that, so that everything can be done locally. But when you first arrive, these things have to be done, so you have to find workarounds. Treatment capacity. So most chemotherapy is purchased initially. So families had to go to the local pharmacy and buy the chemo. Sometimes you get a prescription, sometimes you don't, but you just go and you buy a chemo. What we found were a lot of families would get together and say, here's a vial of chemo, we'll buy this, and then we'll share it. So you end up with slightly reduced doses because you need to both be able to share the same chemo. The chemotherapy is mixed by the nurses at the bedside. So are there any nurses here? Okay, so I don't know how you would feel comfortable mixing chemotherapy, not in a hood, not with anything other than kind of a mask and some gloves, mixing chemotherapy. Frequently there are spills that occur, it's aerosolized, so there's a lot of concerns and safety issues with this. And a lot of training that is needed that sometimes isn't done. So what ends up happening is you end up having delayed treatment because the chemo's not available. Our workaround for this is we started the NGO. The NGO purchases and provides all chemotherapy for free for all of the children. So they no longer have to go to the store and buy it, but we do sometimes still run out, and we do still have people sharing vials because of just the limited availability of what we have. We are working on, there's now an oncopharmacist. We're working on getting a hood for the nurses and working on there's a lot of safety issues still, and a lot of chemotherapy that is administered to the wrong patient. We had that happen last week. There was no safety checks on who the patient was. The wrong dose being given, the chemo orders not being followed. So a lot of that is really important for training, for quality improvement checks is needed. And then last year we got a radiation machine. So the radiation machine was donated from a group in India. It's called the Bobatron, and the Bobatron is great. It is, I think it's a cobalt, and it is being used mostly for cervical cancer and adult therapies. They haven't started using it for children yet, mostly because that requires additional sedation needs and conformal radiation dosing, which they're trying to figure out how to do. So basically, you know what exists, then we start the needs assessment. What is needed, and what do people think is important to address? So initially when I started, our 2-year survival rate was less than 20% at the hospital. This is the view as you drive up the road to the hospital. The line along the road are coffin makers. It's really disconcerting. The government asked them to go off the street, and at least they're down slightly off the street and back now. But it sends a message to families as they're coming to the hospital that's really, really disconcerting. That reason why many people may not come to the hospital. They're afraid that if they go to the hospital, they'll die. So when you talk to people, why are our outcomes so poor? And almost everybody in emergency said cost, right? Cost is incredibly important, especially when families have to pay for everything. I don't just mean the chemo. They had to pay for the laboratory tests that were asked of them. They had to pay for the IV tubing to actually do it. The IV needle, the cannula, gloves. They had to go to the pharmacy and buy gloves, 2 pairs, in order to have it administered. So it ends up being a lot of money. And so people just choose not to have it done. Patients don't know what cancer is. No one really was talking to them about why it was important. You say, here's some medicines, but what disease do they have? Why do they need to take these medicines? How are they going to feel afterwards? And then there weren't any people with any training in pediatric cancer. They were kind of extrapolating some of the adult things, including the same dosing for the adults, medications for the adults, and giving them to the children. So the first thing that we did was we started a cancer registry. Okay, so if you're going to do anything, you need to know where you're starting from and need to understand what change your intervention causes. So you have to have a registry. So we did a hospital-based cancer registry, which links up with CANREG 5, which is used in many countries. And then also created standardized treatment protocols. So these are protocols that have been vetted by the National Pediatric Oncology Low Resource Setting Group. And they are resource adapted. So it's not what I would use here in the US. It's just not feasible. We don't have the infrastructure, the support mechanism, safety mechanism. But we standardized those, so then people were at least being treated by pediatric things. And then started the NGO to help provide some of the support for this. And after the first year of doing all this, absolutely no change. Nothing. So those three things that everybody talked about that were the critical, most important thing did not make any difference in our outcomes for these patients. Okay? So we went back to the drawing board. What were we missing? And when we looked at it, we found that almost half of the patients were abandoning treatment. Meaning they would start and then disappear and then never finish their treatment for various reasons. So this kind of, now people have looked at it, is responsible for about almost a third of the entire difference in outcomes in low-resource countries and high-income countries. It's just this treatment abandonment alone. But treatment abandonment is really complex. Why people don't finish treatment, right? It's not just one answer. So we had to go through and look at what are the different factors. What are things that are contributing to this? Things we saw, the age of the patient, younger the patient was, they were more likely. Time of diagnosis, if they were at the hospital for more than 30 days before they got a diagnosis, they were much more likely to abandon treatment. That makes sense, right? If you're sitting around a hospital waiting for something, eventually it's costing you money, time, family at home. It's going to be more difficult. How far away they lived to the hospital was important as well, and the frequency of their chemo. So the first thing that we decided to focus on was this one. It didn't make sense that if a patient showed up to the hospital, that it would take 30 days before they would get any sort of diagnosis. So we evaluated it a little bit more clearly. So we kind of did a process evaluation, followed patients, figured out what happened, when, and what time points. So almost all of our patients were seen in the emergency room initially, and then they were admitted to the general ward for evaluations. And they either went to the pediatric ward or they went to the surgery ward. They would order lab tests, and then all the lab tests had to be paid for by the parents up front before they would be drawn. So there was some delay in when they actually got done. Sometimes it was days or weeks before it was actually done. So they would sit in the ward during that time. Once the labs and tests were done, it would take 2 or 3 days to get the results. Then based on those results, they would plan a biopsy. The biopsy takes, again, it must be paid for beforehand by the family. So once the family agrees to the cost of the biopsy, then it's scheduled. Once the biopsy is taken, it takes about up to a month before you get the results back from pathology. Often this means the patient is sitting there waiting because they don't know what their diagnosis is and what the next step is. Sometimes they're waiting and not receiving care, other times they're getting just basic supportive care. Then that's when they would refer them to oncology, once they had the results, okay? So the average was 49 days that a patient was at the hospital physically waiting before oncology was ever notified that they might have a patient who has cancer. You add that to a really complex care treatment thing, trying to explain to people why it's important to what cancer is and how, the next steps. A lot of communication barriers and a lot of customs where asking physicians questions is not always encouraged. So what we wanted to do was to figure out how we can shorten this entire process to 14 days. So when they come in, ideally, we'd be notified right away, help them get the right tests, help them get the right labs ordered, explain what it is that they have, why we're doing it. We started this patient navigation program. What the patient navigator did is her job was round 2 to 3 times a week and say, hey, do you have any kids who might have swellings? Do you have any kids who you might think have tumors? If we identified them, then we would see which tests were ordered, what their symptoms were, find out if we could help. The NGO would pay for those lab tests so that they could be done more quickly if the family wasn't able to pay for them. We followed up with the results, and that's huge because things can be ordered, but it gets lost, right? There isn't anyone going back and making sure that those results ever come back. So following up those results and explaining to families, hey, we think your child might have cancer. This is what cancer is, okay, in very simple terms. And this is why we're asking you to do these tests, because these tests will give us options for treatment. And yes, there is a chance of cure for your child. Many places, all they had heard about was breast cancer, pink ribbon, red ribbon, all this stuff that's kind of gone global. They see people who have cancer and think cancer means death. The idea that it was even potentially curable had never entered their mind. And so we needed to kind of re-educate and change that conversation. So the patient navigator, after 1 year, we were able to reduce time to diagnosis by over 50%. Time to oncology evaluation went from 50 down to 16 days. It's still over our 14-day window, but it's a pretty significant drop with just one person. One person. I had one navigator, and that was it, that I hired to do this. This is Judy here, teaching families about what cancer is. We've now made a little video, 2 or 3 minutes long, so that you can listen for many patients who can't read about what cancer is. Our treatment abandonment rate went from 49 down to, I can't read, too small, 29%. So 40% reduction in treatment abandonment after 1 year alone with a single person. And our survival rate almost doubled with just a single intervention of a patient navigator, okay? So not high tech, not a lot, one person dedicated to education and follow up and helping to move things along quickly. So then we go back to the drawing board. Okay, great. That was fabulous. We're still not where we want to be. What else can we do? Distance, okay? So the average travel distance for our patients, this was made by a previous DGHI fellow, Christina Chow. So the average travel distance is about 120 miles, so about 4 hours by car for most of our patients who are coming to see us. Wait for it. You can do it. Okay, so the average travel distance is about 4 hours by car, and what we found is if it was greater than 6 kilometers, there was increased risk of abandonment. So the NGO started a hostel that was about a 5 to 10 minute walk-ish, 10 minutes probably, from where the site of the hospital is. So at the NGO, we have a nurse who lives full-time. So patients can stay there free, no charge. They receive 2 meals a day. And then there's a cook who provides those meals, and then also a social worker, which we added on the next month to kind of help with some parent education classes there, talk to some of the families to get them. I need to figure out how to increase this so I can read this. So this is Annie, and when we started this, we kind of interviewed parents to understand what they wanted, what they needed from this hostel. I'm just going to read you an excerpt of this. So we thought that when you get cancer, that's just it, you're dead. But the doctors gave me hope because they told me they were going to treat my child. When she was diagnosed, I didn't care where we needed to go to be treated. I just wanted her to be cured. I went to the ward and told them I had no family in Mwanza, and they had come here suddenly, and I begged for a place to sleep. We slept in the waiting area and later on in the inpatient room. They said I should look for somewhere else to sleep because these beds are only for sick people. I told a nurse I didn't have a place to go. I didn't know what to do. Should I go back to my village? She gave me the number of Donata at the hostel and told me where it was. So I called Donata, and when she arrived at the hostel, she popped outside the gate and welcomed us. I'm not sure how that was translated to popped outside, but you get the point. When you look at this year, it was an extremely difficult one. We tried to sow the fields, but the harvest wasn't good this year. Also, when you have a family, there are lots of challenges. You can work for 3 weeks and make $30 and owe someone money, and your kids are hungry. But the family is happy to see Anik better. Since I have been here, they have been insisting she continue treatment and working hard to keep her heal and fighting for me to survive. What gives me heart is seeing Anik get better to come to where she is now. I am happy and has given me the heart and energy to keep going. And Anik is cancer-free. So, one of our master students from last year did an evaluation of what the impact of this hostel had on our patients. And this is Austin here, Austin Morgan. It really, okay, it's just blurring on my screen. And what we found was that it was a 37 versus 47% overall survival rate, so almost a 10% increase in survival if you use the hostel services. Doesn't mean you had to stay there the entire time, if you even use them at all. And this was most poignant if you look at it, that first kind of 3 months of treatment. So the highest intensity of treatment is where we see that largest gap, that largest difference, when we're able to reduce the number of patients who die early from complications or from abandonment or from other things. And then we looked at the quality of life, and the one on the right is the PEDS QL, the emotional impact. And parents and patients who used the hostel had higher emotional quality of life. When we did qualitative interviews, it was they felt they had a sense of community. They were able to kind of work together, talk about their problems together, work together. When one patient was in the hospital, other family members would come and bring them food from the hostel to the hospital. So it was a sense of community, and we were really kind of excited about that large of an impact. Late effects, some of them didn't work out, and that's from relapses and other things, which is more similar to what we would see elsewhere. But even all the way through, there's a significant increase in survival benefit. So the next part to tackle is we need more people to come. Okay? We are only seeing a fraction of the number of patients that we know. Right now, we see, well, at the time, we had about 150 or so new patients a year, and based on our population size, there should have been 3,000 patients, okay? So we started community awareness campaigns to go into the community. So we had a local group, it's actually a parent of one of our kids who works kind of with a NGO and various church groups in the area, who became an amazing advocate. Parents of children who have cancer are an incredible resource for education, for advocacy for your patients. And so it's sort of this untapped thing that people don't often think about, but should. And he organized a group of dancers, and they went out into the community, and people would dance, because everyone wants to come see dance. And then, hey, thanks for coming, let me tell you about pediatric cancer. And so it worked really well. People were interested, we went to schools, we went to local kind of villages and talked lectures about what was going on and what pediatric cancer was. And we did radio ads, posters. This is a student who's doing her Fulbright with me for the year. She did radio ads, posters, village meetings, created symptom awareness posters in 2 different languages, and then put them up in key areas to look. And what we saw is over the last 2 years, our numbers have gone from about 120 a year to 213 new patients last year. And this is continuing to growing. We did staff awareness meeting. So the people in the community thought someone might have cancer, then they would refer them to their general local hospital. But if no one there thought or knew what cancer was, it wouldn't go any further. So we did staff awareness training. So in the Moans region, we had one representative from every hospital, which was about 200 hospitals, so district hospitals, regional hospitals, everything, come for training. And we taught them, spent one day talking about the symptoms, the treatment, gave them all posters to bring back to their clinics to post so they could see. And what we saw is the number of referrals per month from several of these areas increased. So Ilamela, Yamagana, some of the more rural areas increased. The one that's highlighted in red, Sengerema, so this is a slightly special one, in that you see post-training we had 0 referrals. The reason is that we trained them to be able to provide the chemotherapy as well. 2 of our nurses from the US came over, provided their nursing staff training on how to administer chemotherapy, the side effects of chemotherapy, to a point where they feel comfortable doing basic chemo and treatment of these patients now. And they no longer refer them to us. So, which is great. So this is where we are today. Our 2-year overall survival rate. So it's only up to 2017. So our overall survival is 44% right now, up from 19%. And our abandonment rate is down to 20%. Last year, our abandonment rate was 12. Okay. Our 1-year overall survival rate is about 53 right now. So we've made a lot of progress in a little bit of time. So these are the hopes for the next year. So this year, next year. So first is we're trying to look at nutrition, because nutrition is such a key factor in cancer response. So not just the presentation when people show up and their survival, but how the chemotherapy affects their body, how they respond to that chemotherapy. So our current master student, Yadu, and Anna, who's from NC State, nutrition science student, was done now, is they did a baseline kind of nutritional status, along with Abduli was working on this in another country, in Uganda, to try to understand what percentage of our patients are severely malnourished. And over 40% of our patients had severe malnourishment. Okay, so when you talk about moderate malnourishment, I think it was 65 or 70% of our patients were severe or moderately malnourished. So a significant portion of our patients came in already at a loss. Okay. They required additional work up front to try to even have the same metabolism and same response to chemotherapy than their counterparts who are not malnourished would. And then they worked to kind of create educational things for parents and providers to be able to talk to patients about the importance of nutrition. Future nutritional supplement intervention design is what Yadu's working on for this year. We then worked with Dr. Vasudevan Lavania, who does some mHealth stuff. What we found is, even though we created these protocols, less than 20% or so, 22% of people actually followed the protocols. So even if they were there and written, they weren't being used correctly. So we created this automated digital health app that they can enter in the information, and the navigator, the patient navigator, Judy, and we now have 3, enter in the data, and then it will automatically tell you, based on this labs and this, and here's your diagnosis, this is the chemotherapy that you need to administer. The chemotherapy automatically dose adjusts based on if they're malnourished. It automatically dose adjusts based on the labs. And so it helps improve that compliance and making sure that people are getting the right treatment. And the last thing is, it's really important to train people to be trainers, because we can go to every village in the world and talk about things, but unless kind of it comes from within, unless the discussion changes and it's no longer about this person has cancer because they were bewitched, this person has cancer because their parent did something wrong and therefore they're being punished, which is still very prevalent in our region. We are training kids, and these are some of our training sessions. So we have the parent training session in the top that's being done by our social worker, so people can go back to their villages when they leave between appointments and talk about cancer and express to people what it is in very simple things. The bottom left is one of our pediatric cancer awareness events that we did. It was on the National Peds Cancer Day, so the end of Peds Cancer Awareness Month is September. So we did it there, and these are a bunch of our patients and their parents who came to educate the community about their experience with cancer. And this is from the local schools. They did a poster competition to write about simple signs and ways to get other children aware of what cancer is, that it can be cured, and that there's treatment for it. that we chose our winners and are going to put it up and publish them around the region. So we still need to reach more people, however. So this is the current catchment area of where we are. So 3 hospitals and kind of what part of the country we currently cover. So what we did is this past year, recently, we have launched the Pediatric Oncology Network. And so it's a national childhood cancer network, and I'm really excited about this. Basically, it's with local NGOs, mine, and then TLM, FCG, the hospitals are collaborating together and helping to open other sites so that they can treat children with cancer, to allow kids to be treated at any of those sites with the same treatment protocols, the same ability, and then we can transfer them between as needed. So right now, this is what it looks like. We currently have only about 57% of patients that are covered by cancer care within a 4-hour drive. So these green parts of the country, that's about 4 hours to get to one of the now 5 sites that we have trained to be able to provide cancer care. And this is what we're proposing. So we have a single hub, and the national hub will be in Mbili because it's the national hospital and they have the most resources, the largest program. Then there's the tertiary hospitals where we can all treat the majority of pediatric cancer cases. Then we kind of work on a hub and spoke. So these are the sites that we hope to train up to be able to do initial kind of stabilization treatment, diagnosis, and then transfer them to one of the green star areas. And these are the smaller sites that we hope to provide additional education so they can stabilize. They may not be able to do any of the diagnostic testing, but at least figure out they might have cancer, send them to one of the other sites directly to be able to get treatment. A lot of collaborators who have gone and done this, both at Bugando and at Duke and all the different hospitals. So I'm greatly appreciative for everyone's work. And then, any questions?
Two questions for you. First one is, how much of the training of capacity building and other providers are you doing in person versus remotely? And the second one is, why should you not wash your fruits and vegetables with soap?
I'm gonna defer the second one to you guys. But so on site, I'm there 6 months out of the year. And so it's constant. And then for continued kind of capacity development, I round every day remotely with the team. So at 4 a.m., I round with them and go through the patients for that day, discuss what they found and how we can manage it. The other really key thing that's been instrumental is WhatsApp. So we have created WhatsApp groups for brain tumors, for kidney tumors, for eye tumors from all over the country. And so that's been helpful. I'm the only neuro-oncologist in the country. And so all brain tumors, adult and pediatrics, they send me their pictures, and then we're able to discuss treatment options and that kind of stuff, so remotely. So that's made a huge difference. The washing the soap one, I'm gonna defer.
Yeah, so you're, I was the one who created that, and you're not supposed to wash with soap because it can leave residue. Like if you use hand soap or antibacterial soap, it can leave it on the fruits and vegetables. So we recommend either peeling them or washing them with, like, we would boil water and run that over it because we don't want to leave extra residue on the fruits and vegetables.
Yeah. I just want to first thank you for just this wonderful presentation and the incredible work that you're doing and the impact that you're having. And my question, I guess, is a little more personal. Like, how do you deal with the burden of sort of being the only, as you said, pediatric neuro-oncologist in an entire country, and really, you know, I just would like to kind of hear a little more about sort of what your own kind of personal orientation is toward your work and how you continue to find sort of the motivation and the perseverance when the need is so incredible and so great. And then maybe the flip side of that is, like, what gives you the most hope? Like, what makes you the most excited as you think about the years ahead and the work that you all have done at BMC?
Yeah. So it is a very different feeling. When I'm here, I'm one of 10 pediatric oncologists, right? And we only have 80 new diagnoses a year. And so we have constant tumor board discussions, we have constant intercollaboration discussions, and so you feel that you're never alone. I struggled in the beginning there because I was making decisions in a very gray area without final diagnoses, without the ability to make proper diagnosis as I've been fellowship trained to do. Very disconcerting. And so it took some time to kind of realize that if I didn't do anything, they would die. If I did with what evidence I had, my best decision, my best options, I had a chance. And what I have eventually done is I still will talk to my colleagues back at Duke periodically, but I've also found it to be a little bit difficult in that I would say, I'll ask about this question and then here it's like, we'll run this test. Well, that doesn't exist, right? So it's a different frame, and unless you've been there and understand, it's not always translatable. So there is now a Pan-African tumor board that was started. And so about 8 or so different countries, every Monday we go online and share cases and discuss interesting problems or get advice or share protocols, and that has been hugely helpful for me. The other thing that I do now is the other pediatric oncologist who is in Dar, she and I have weekly phone calls and we go through the patients and talk about people that are maybe like we have a question, so, is this the right treatment or is this the right treatment, and what are our options? And so I found that through doing this, what was much more of an insular view of what pediatric cancer was here in the US. I just returned from the International Pediatric Oncology Conference and spent the entire time just talking to people from all over the world about how they treat children in their countries. And what we realized is we're all kind of struggling with the same thing. And so what we just decided is we had our first planning meeting for the East African Pediatric Oncology Society so that we can, as a group, work to come together with protocols and support and get to procure chemo from one source and distribute, get one source to get the pathology, and then work together as a group. But I have found that, and the thing that kind of keeps me going is every once in a while you get bogged down in when things don't work well. I've had a few recent kind of rough cases. And when every once in a while I'll pull up that one slide that's like shows the trajectory of where we've been and where we're going. And then you just kind of realize that, okay, even though days are bad, you see that we have doubled survival, more than doubled survival. And so with very little resources. And there are 3 pediatric oncologists that are finishing their fellowship this year. So as of next year, there will be 3 Tanzanian pediatric oncologists in the country, and I am super excited about that because that then gives me the opportunity to kind of help build within Bugando local capacity even more, and then I can step back and help guide some of the research parts of it, but also kind of supportive care development.
Hi. Really good talk. Thank you so much for sharing your experience. I was curious if you could touch on, like you talked about how your referral rates and diagnostic rates are going way up. What are you doing internally to make sure your capacities can kind of match the increased referral rates? And then kind of my second question is I wondered if you might be able to give more details about your funding avenues, particularly as it relates to your hostel and things like that for parental support.
Sure. So the increased capacity is we have the one position who we've sent to do the fellowship training, so there'll be at least another full-time position, and then I've trained one more registrar who is dedicated to pediatrics as well. We have 3 physician navigators, patient navigators now, so we've had to kind of build up. The other thing that we've done to kind of increase the capacity is provide education to the other departments. So the Department of OB, the Department of Peds, ENT, surgery, so that they know what to do, that kind of basic. One of the Peds residents here created a book that's like a what to do for pediatric cancer diagnosis book, so that if you get someone who has an abdominal tumor, it kind of gives you a logarithm or algorithm that says, make sure you order these 3 tests to help us understand what the next step should be. And so we've been trying to do things to task shift a little bit so that it's not just me and my small team, that everyone in the hospital is able to take part and understand. And what's up? A lot of what's up. And the second one
Was just kind of your funding avenue for parental support.
So the all of what I do is donor So a part of it is through NIH grants, the actual research component. So setting up my registry and setting up the mHealth app and all of that is through NIH research. Everything that is for supportive care for the patients comes from my NGO, iCare, and so we just fundraise, and then we have one grant to pay for the rent for the house and to pay for all that. Total cost of running is probably about $15,000 per year. And so, yeah, it's all individually funded and donated. If anyone is really good at social media and would love to do that kind of stuff, let me know. It's not my forte, and too many hats. Yeah.
Thank you for the presentation. It's very impressive. Established the thing from nothing. It's very remarkable. So my question is, how did you engage with the local and national government there?
Mm-hmm.
Is there any particular things you need them to help with you? Are they very supportive, or they just like?
Now they are more. Initially, people think peds cancer, it's such a small thing, so they all hear about breast cancer and turbo cancer and these big things that get a lot of funds to them. Peds cancer is kind of like, eh. But the hospital itself is now open, and we're trying to figure out how to exempt the cost of all of our patients, and so we're trying to move towards that. The WHO making this a World Health Initiative has really helped in that now we have had meetings with the Ministry of Health. We've had meetings with local like drug procurement agencies, and we've done big costing studies to help move policy in the area to show that I think the average cost, including everything, so fixed, indirect, everything, was like $1,000 per patient for curative treatment, which is even in a country with low resources, like that's hugely cost effective if you want to look at it. So I didn't put that data in here, but now that we have that information and we've done that road mapping to figure out where the best place to invest, we've gone to the Ministry of Health and kind of presented them with these things, and we're working with them on accessing chemotherapy and changing that plan. The new Minister of Health, who was just elected a year ago, is interested. And so now we finally have an avenue to have these discussions.
Thank you so much.